out that in the other patients, we saw changes of 3-4 points. Here we see enormous changes. And we had a few patients that came in on walkers and walked out without. And we thought they were cheating. They were just showing they have Parkinson's, but really didn't. But if these patients, and in fact, we looked, these patients belong to this group, then their data is real. They actually walked in on walkers and walked out without. And so we know that postural instability and gait difficulty responds very strongly to our drug. Now, I'm giving you a little background here that patients can be subdivided into postural instability and gait difficulty, but also into tremor dominant. In the tremor dominant patients, we saw that they respond, but not nearly as well. So we want to go back and see what makes them tick. Because what we are learning is that we can't go by a Horn and Yahr scale. We have to figure out what does this drug improve in what patients. And we have a long ways to go because it took us a little while to figure out that we had to first find a deficit and then see how that deficit gets improved. So then we went to MMSE. This was an exploratory endpoint, but interestingly enough, we saw that the whole population, as I was saying, most Parkinson's patients don't have cognitive decline. So the whole population shows a very minor cognitive decline. However, when we took the population that has a cognitive decline, which is 12%, they declined 1.5 points. And if you look at Alzheimer's, 3 points or so is the average, 2 to 3 points is the average decline of MMSE in an Alzheimer patient. So these patients behave more like Alzheimer patients. And in fact, if we give them our drug, they improve. Okay, here we prevent the slowing, we stop the progression in the whole population, but in the affected population, we improve cognition. I want to point out that MMSE 20 to 26 is exactly where we saw our activity in Alzheimer patients. In Alzheimer patients, we saw that our drug worked in 1 month at MMSE 20 to 30, at 3 months at MMSE 21 to 24, and here, if we add Parkinson's, at MMSE 20 to 26, which means our drug improves cognition at MMSE stages more than 20. So this is very interesting because while these are Parkinson's patients, we can use this data to substantiate our Alzheimer's data. And we can also help Parkinson's patients not progress in dementia or to dementia. The drug is safe. You have heard me say this now for everything and everybody. In fact, it doesn't matter how we look at it. Whether we look at treatment-related adverse events that are just treatment-related or potentially drug-related, we have the exact same percentages, be it in placebo, 10 mg, 20 mg, or combined. And serious treatment adverse events, we see absolutely none, neither in placebo, nor in the high group, nor in the low group. So the drug is safe. We have now way over 1,000 patients treated from between 1 day and 6 months. And we are putting together a data safety base for the FDA, but the drug, we are 100% sure, is safe. That's one thing that is true for all our treated patients. So this is where the state of Parkinson's disease is. I showed this for Alzheimer's, but I'm showing the same for Parkinson's. An untreated person or a person on placebo will decline in whatever function that they're most affected with over time. In Alzheimer's now, we have Leqembi, which is disease modifying. Actually, as of today, we have donanemab. They're disease modifying. They slow the disease. They don't improve. And then in Alzheimer's and in Parkinson's, we have symptomatic drugs. Every single drug approved for Parkinson's to date is symptomatic. It's mostly dopaminergic based, and it improves cognition, and then it slowly goes back down to where the patient would have been if they never took any drug. What our drug does, as far as we know, it improves whatever scale, be it UPDRS 2 or 3, it improves it above what the existing dopaminergic drugs do, because we gave it on top of the dopaminergic drugs. And then we don't know how it progresses long term. Up to 6 months, where we have up to 6 months, we know that it stays up here. We see zero downhill slope. And at some point, maybe it will start to go downhill. But at this point, we really do not know yet. So we know our drug is better or as good as the existing dopaminergic drugs, but improves the effect of dopaminergic drugs by double. And long term, we hope it stays up there. So where do we go from here? We will summarize this data and submit it to the FDA and ask for a meeting in October. And at that meeting, we want to ask to file an NDA here. I'm not putting it in writing because it's aggressive, but it's not that aggressive because the drug works in the whole ITT population. We just have to use different measures to find how it works. So we will ask for an NDA here. If they say no, we will start an 18-month study and break it off with an interim analysis at 6 months to confirm that it has symptomatic effect, and then continue for 18 months so that we can also show disease-modifying effect. We will also have an open label study for all the patients that have already participated in a study so they can get the drug going forward. I've had a lot of patients asking for that because they felt better on the drug. Now, if we talk about FDA in general, with this study, we really also add data to our Alzheimer's disease program, because we can say now that in Alzheimer's, we have cognitive improvement at 1 month, 3 months, and 6 months. And in Parkinson's, we can say that our drug works on every patient in the Parkinson's population, even though we may need a different scale to measure that. And I think there is one more thing I wanted to mention. We have it in the news releases. How about the endpoints? As most of you know, or some of you know, we started out with UPDRS2 plus 3. I want to point out that Denali and Cerevel on clinicaltrials.gov also have 2 plus 3. The reason for that is that if 2 and 3 are good, 2 plus 3 is better. You put two good things together, you get additive value. So we all felt, and I can talk here for Cerevel and Denali, we all felt that we would get statistically significant data. Then the FDA told me, I'm not sure what they told anybody else, but they told us, don't use that. It's not an accepted endpoint. Use 2. And the reason they said use 2 is that they feel that when patients tell in their words how they feel, how they work, how they function, how they clothe themselves, how they eat, it's a better scale to measure progress for the patient. Maybe not for the PI, but for the patient. Whereas the UPDRS3, it's the PI telling you how much do you shake, telling you walk a little bit and watching you walk. So we changed to UPDRS2. And honestly, I was scared because in our phase 2A, we did not have statistical data in UPDRS2. We had highly statistical data in UPDRS3. But once we figured out how to analyze buntanetap, we found that it works in UPDRS2 just fine. It works beautifully. And it works in 3. And then even though the FDA doesn't like 2 + 3 for you guys, we did 2 + 3 because that was our original endpoint. And then we also did total. So that's it. Thank you very much. Now we want to move to question and answers.
Thank